Good afternoon, everybody. I'm so pleased to be part of this conference today. Of course, I would normally be present, and I have very good friends in Egypt and Cairo, and I'm hoping all of you are keeping very safe, and I'm hoping that we can meet up again very soon when this pandemic has been resolved. I'll try my best to keep to time. This is going to be a fairly short presentation. The title is Stage 1A Cervix Cancer, an overview. So what I'm going to do is present our experience in Gateshead of Stage 1A cervix cancer. And our practice has predominantly been conservative, where the majority of our Stage 1A cancers are treated with loop excision. As you know, cervix cancer affects young women, and for many of these women there are fertility issues. But even for the older women, there's issues around womanhood and whether hysterectomy really is necessary. So I've actually subtitled this presentation as Outcomes Following Loop Excision as a fertility sparing policy with critical emphasis on margin status. I don't have any particular conflicts of interest for this presentation. I've listed my other conflicts of interest here on this slide. As you all know, Stage 1A cancer is diagnosed by microscopy. There are very clear pathological definitions of measurements relating to Stage 1A. So Stage 1A1 would be less than or equal to 3 millimeters in depth with a horizontal spread no greater than 7 millimeters. And 1A2 would be again diagnosed by microscopy, where the depth would be between 3 and 5 millimeters with a horizontal spread no greater than 7 millimeters. So that's Stage 1A cancers. In other words, they're small tumours. They predominantly have a good prognosis. Certainly in the UK, the great majority are identified through the screening programme, and we would expect good outcomes from these cases on the assumption that they are appropriately treated. And the question really is, do they all need a hysterectomy, and can they be managed with conservative methods? So for the UK, cervix cancer is not that common. We clearly have a successful screening program. There were just over 3,000 new cases in the UK, and this is data from 2018. And the great majority of these are in fact diagnosed as Stage 1 disease, almost 60% in fact. And again, that's partly down to the screening program, but also because of the awareness that there is amongst the UK population in women who present with either postcoital bleeding or intermenstrual bleeding or postmenopausal bleeding. So there are numerous guidelines relating to management of cervix cancer, including Stage 1A disease. This is the London guidelines. There are the ESMO guidelines. There's also NCCN guidelines. And these are the guidelines that I was involved with. They're the ESCO guidelines, which we did in conjunction with ESTRO, but also the European Society of Pathologists. This is available on the ESCO website. So anybody, whether you don't need to be a member of ESCO to be able to download these guidelines, they're available for all, and it covers what the European practice is for management of cervix cancer, including Stage 1A disease. So these were the personnel involved with the development of the guidelines. As you can see, there's quite a lot of people. We met on a number of occasions over a 2-year period. It's a combination of surgeons, radiotherapy consultants, as well as pathologists, and we covered all of the topics related to cervix cancer. For 1A disease, we reviewed a considerable amount of evidence, and there's a lot of published evidence relating to 1A disease in relation to single centre outcomes or national outcomes. There's Cochrane reviews, as well as other systematic reviews. So these are the publications relating to Stage 1A disease. And when we discussed the issues from these publications, we identified a number of controversies. And those controversies predominantly related to practice in the US compared to practices in Europe and elsewhere. And they related to the need for radical treatment in stage 1A2 disease, whether there was a need for lymphadenectomy in cases showing evidence of lymphovascular space invasion, whether all cases or high-risk cases needed a reflex hysterectomy as part of their primary treatment, and whether there was a need for delayed hysterectomy after fertility completion. So these were the main controversies related to stage 1A disease. And as I say, we reviewed the evidence that was published, and the recommendations are available on the ESCO website. So what I'm now going to present is our practice from our centre, because being part of this group made me question what our practice was and what our outcomes were. And our practice is predominantly conservative. In general, we're comfortable with carrying out an excisional treatment for stage 1A disease that may only involve a cone biopsy. What our intention is to achieve complete excision of the invasive component as well as the non-invasive component, and we only really perform a hysterectomy if carrying out an additional loop procedure is not feasible, or if there are additional reasons for carrying out a hysterectomy, such as heavy periods or patient preference. And in terms of pelvic lymphadenectomy, our general departmental policy was to only carry out a lymphadenectomy in stage 1A2 disease and very occasional stage 1A1 cases. So that's generally our practice. And as I say, what I'm going to focus on mostly for the rest of the presentation is the outcomes from our department. The study objectives were firstly to determine regional incidence of stage 1A disease, whether it was comparable to the rest of the UK. And in terms of outcomes, recurrence rates of invasive disease after treatment for stage 1A1 disease, recurrence of CIN after treatment for stage 1A1 disease, and also what our statistics were for reflex and delayed hysterectomy rates. It was a geographical and population-defined study. In other words, it was retrospective, but we had clear definitions of what our geographical area was and what our population was. We analysed all of the cases that were referred to our centre. All of these cases had central pathology review from a pathologist that is specialised in gynae pathology. We also cross-referenced that with all of the hospitals that refer to our centre, of which there are about 10, and we checked our database against their database. We also compared the produced database with the national database and organisational database at the National Cancer Registry and the Death Registry to ensure that we had complete number of cases from our defined geographical area and population. We then obtained detailed follow-up for all of those cases by contacting the GPs. And as I say, this allowed us with reasonable confidence to have collected all of the stage 1A cases within our geographical area and our population of the north of England, which included 1.6 million women. The time frame was a 10-year period between 2006-2016. So in terms of results, I'm going to break it down in terms of diagnosis, treatment and outcomes. In diagnosis, we identified over that 10-year period in that 1.6 million population of women, 247 cases of stage 1A disease. The very great majority was stage 1A1, that's 94%, with only 6% being 1A2 disease. In other words, that's 1 to 2 cases per year over the 10-year period that we classified as stage 1A2 disease. So stage 1A2 disease really is very, very uncommon. The very great majority are stage 1A1 disease that carry a better prognosis. The incidence that we defined from these statistics were 15 per 100,000 women, which was comparable to the rest of the UK. The very great majority of these stage 1A cases were of squamous histology, and no matter it's highly publicized, the number of cases that had lymphovasus-based invasion was in fact very small, only 5%. And I should mention here that, as I say, all of our cases did undergo central pathology review. So we're very confident that what I'm presenting here in terms of 89% squamous histology with 5% LVSI showing positivity is accurate. And you can see from the brackets that, in fact, very few cases of stage 1A1 disease actually have LVSI, less than 3%, and for 1A2 disease, it's 33%. The very great majority of the 247 cases were actually diagnosed by loop biopsy or loop excision. And again, this is reflective of the screening program within the UK. The great majority presented with cytological abnormality during routine screening. Only 4 cases over that 10-year period were picked up as an occult case, in other words, incidental, as part of their hysterectomy for other reasons, which were predominantly heavy periods. So in terms of diagnosis of the patients that had an initial loop excision, that initial loop histology specimen, in 22% of cases, there was complete excision of the invasive disease and CIN in that initial loop. 11% had incomplete excision of invasive disease, and that included obviously pre-invasive disease, and 67% had complete excision of the invasive disease, but incomplete excision of CIN. Now, clearly that still carries a certain degree of risk in that, especially with adenocarcinomas, but also with squamous cancers, you can get multifocal disease. So being reassured that you've got complete excision of invasive disease does not mean that you can be reassured that there isn't another focus of invasive disease elsewhere within the pre-invasive pathology. So our general recommendations for our department is that if there is incomplete excision of CIN, they should have an additional loop procedure. So in terms of treatment, our overall statistics are that 20% underwent 1 loop excision as part of their overall treatment. 53% had 2 loop treatments as part of their complete treatment. 1 patient had 3 loop procedures, and of all of the cases, 27% had a hysterectomy as part of their primary treatment, and that was either because further loop procedures were not possible, because there was insufficient cervix remaining and it was felt unsafe to carry out a further loop procedure, or because the patient requested it. Of those that underwent a pelvic lymph node dissection, there was 7% in total. That includes pretty much all of the 6% of cases that had a 1A2 disease and a small number of cases of 1A1 cases. Of all of the patients that did undergo pelvic lymph node dissection, and I should mention that in all cases the lymph node dissection was carried out laparoscopically, the lymph nodes were negative. We did not have a single case of positive lymph nodes in any of the cases that had stage 1A1 disease or stage 1A2 disease. In terms of delayed hysterectomies, as I say, we followed all these women up, and 7%, in other words, 13 out of the 177 that did not undergo an original hysterectomy, underwent a hysterectomy at a later date. And for the majority of these cases, 9 out of 13, it was usually because there was difficulty performing cytological surveillance. And mostly they had like an inadequate smear because of their previous loop treatment. And on the basis of the history and inadequate cytological surveillance, the decision was made with patient approval to have a hysterectomy. In only 4 out of the 13 cases that had delayed hysterectomy, was it because the patient had then completed her family and then wanted a hysterectomy for completion. In terms of outcomes, I'm going to look at CIN first, in other words, pre-invasive disease. Of the overall 247 cases involved in this audit, only 8 cases went on to develop subsequent CIN during the follow-up period. That's 3% in total. The majority of these were in fact only CIN1, that's 5 cases. 2 cases had CIN2, and 1 case had CGIN, and there were no cases of CIN3. So in terms of invasive disease, as following treatment for stage 1A disease, we had 2 cases of cancer or invasive disease after treatment for 1A disease. That's an overall statistic of 0.8%. That's 2 out of 247 cases, and there were no deaths. And this was with a median follow-up of 46 months. In other words, almost 4 years. The 2 cases, I'll just provide some additional information of these cases. Both cases where there were recurrences, the primary tumor was in both cases a stage 1A1 cancer and LVSI negative. In other words, low risk cases. They were not the 1A2 cases, and they were not the 1A1 cases with LVSI positive. They were the low risk cases. But in both cases, there was CIN3 at the margins of the surgical specimen. The first case actually underwent a hysterectomy, and the cancer was identified incidentally. She had CIN3 at the vaginal margin. The second case had a loop treatment with CIN3 at the ectocervical margin. So it's correct that our standard policy during this 10-year period was that they should have had additional treatment, but for whatever reason, our standard departmental policy was not followed, and both cases went on to develop an invasive cancer. So in terms of outcomes, the relative risk of invasive disease following hysterectomy, which is 1 case out of, I can't remember the exact number of hysterectomies now, but the overall statistic is 1.4%. The relative risk of invasive disease following loop excision is 0.6%. So the relative risk following hysterectomy versus loop treatment is not significant. Accepting these are low numbers, you can see really from what I'm presenting here that the risk of developing an invasive cancer after treatment for stage 1A disease, certainly in our centre, which does have a conservative approach to treatment, was extremely low and was not related to whether they had a hysterectomy or a loop excision. What wasn't most important isn't so much whether they had a hysterectomy or a loop excision, but whether the margins were clear. So of 230 cases that had a clear margin, there were no recurrences. Of 17 cases where there was incompletely excised CIN, 2 cases got cancer during the follow-up period. And when CIN3 was incompletely excised, of which there were 6 cases, 2 cases went on to develop invasive cancer. So really you can see from here that the risk of developing cancer as an outcome following treatment of stage 1A disease is based predominantly on whether there's CIN3 present at the surgical margin. And this result is statistically significant. And when I present it graphically, you can see really it's quite clear really that the ideal should be to aim for clear margins. In other words, no CIN or invasive disease at the surgical margin. Low-grade CIN, again, our results showed 0%, so that would appear to be low risk. If it's CIN 1, CIN 2, it goes up to about 12%, and then CIN 3, it's 33%. So really, I think no matter it's a single center study, you know, I think there are important messages that we can gain from this audit, which is that the objective of the treatment should be to ensure complete excision, certainly of CIN 3, ideally of all CIN. So the conclusion is that our regional incidence was 15 per 100,000 women. The recurrence rate of invasive disease from our centre after treatment for stage 1A disease was less than 1%. The occurrence rate of CIN overall was 3%, and the reflex hysterectomy rate was 27%, and the delayed hysterectomy rate was 7%. And I would say that our most obvious conclusion from this audit is that irrespective of the loop excision or hysterectomy treatment, it is margin status that defines the risk of recurrence. Okay, thank you very much. And I'm open to questions from the floor. Thank you very much.